Hello world, my name is Dr. Sohom Das. I'm a consultant forensic psychiatrist and I live and work in London. I assess and rehabilitate mentally disordered offenders, or what the tabloids might call the criminally insane. I regularly assess defendants in courts, in prisons and in secure special psychiatric units that are reserved for the most dangerous and violent patients. Although I specialise in criminal psychiatry, I also have expertise in most aspects of mental health and mental illness. This video podcast series explores a range of topics, and it's for the layperson who might be interested in learning more about severe mental illness. So I'm talking about chronic, lifelong illnesses that can hugely impact on the sufferer's functioning. So diagnoses like schizophrenia, bipolar affective disorder, autism, and I will analyse how this is sometimes related to offending, and I'll share with you a bit about life from the perspective of a psychiatrist. This particular podcast episode is about delusions. So I'm going to tell you the definition of a delusion. I'm going to tell you about the different types and classifications and how they're related to specific psychiatric diagnoses. Now, anybody can look up most of that on Wikipedia, right? But what I'm going to do is I'm going to try and captivate you by talking about specific cases that I've personally assessed and treated. I'll be handpicking the more interesting cases and stories from my 15 years experience of working as a psychiatrist. Just as a little trigger warning, I am a forensic psychiatrist, so a lot of my stories are going to be related to offending and violence, so it might not be for the faint-hearted. You've been warned. So sit back and enjoy, and welcome to A Psych for Sore Minds. The first logical question has to be, what is a delusion? The formal definition of a delusion is this: a delusion is a fixed belief that's based on inadequate grounds and it's not amenable to rational argument or evidence to the contrary. And it's not in sync with regional, cultural and educational backgrounds of the sufferer. So blah, 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 that is a lot of words, but let's break that down. Not amenable to arguments or evidence to the contrary is a key feature. So I remember once seeing this young Russian woman, let's call her Miss R, in a healthcare unit in a female prison a few years ago. And she had these delusional beliefs that most of the members of staff there were imposters and were also Russian spies. Incidentally, she was in prison she was on remand for assaulting her own mother with a rolling pin. And at the time of that offence, known as the index offence, she was suffering from Capgras syndrome, which is a very rare delusional misidentification syndrome, where the sufferer thinks that close friends or family members have actually been replaced by identical imposters. So that was what was going through her head at the time. Now, for some particular reason, Miss R seemed to like me. She believed that I was the only genuine doctor on the unit. And I wish it was because of my amazing clinical skills, but I actually think it was just a bit random. Miss R tried to collude with me, so she would pull me aside when I was doing my rounds and she'd whisper about how we could help each other escape and that we have to look out for the other imposters. But in particular, Miss R was really paranoid about one particular nurse who happened to be Spanish. And she had misheard the nurse saying her own name and she thought it was a Russian name. And then Miss R started to believe that this nurse was like the head spy. And so she refused to take any medication or refused to take any food off this particular nurse. And she even once tried to throw some hot tea through the wicket, which is like the hatch in the doors of the cells of the healthcare unit in prison. And what stood out about this interaction to me was that this nurse really tried to argue with Miss R. And she even showed her like a hospital ID. And she printed off some information from the internet about her surname to try to convince Miss R that this is a common Spanish surname. And this nurse also had a copy of a staff magazine, which she happened to have been in recently with her name and her picture in. So there was a long, convoluted argument. And the thing is, you cannot win an argument against delusions. So I was just kind of watching this from afar and I was mildly amused. and the nurse spent at least over an hour arguing with Miss R. But then what's interesting is that Miss R developed a new set of delusional beliefs to kind of sustain or to support her previous ones. So she was then convinced that this nurse had swapped her old ID with another member of staff, and she was convinced that she had a fake magazine printed. So anyway, back to the definition of a delusion. As I was saying, a delusion cannot be in sync with the regional, cultural, or educational background of the sufferer. So for example, some religious groups might believe that the devil exists, and that certain acts will lead them to, hell and damnation, but that is the result of ideology that's been imprinted from an early age. Whereas on the other hand, I once assessed a patient who had no kind of religious background, but who believed that the devil was specifically trying to kill her because of a sin she'd committed many years ago. She had an abortion. So this patient was really preoccupied with it, and the guilt began consuming her thoughts, and she became so anxious that she couldn't actually really function. So that was an actual delusion caused by mental illness. Another example might be if a racist is convinced that a man of colour, such as I, is of inferior intellect or wants to take their jobs. Again, that's not delusional. It's just in keeping with their particular cultural context and their social circle. I think the word delusional is often mentioned in casual conversation, and it has a different meaning to the formal psychiatric definition. And this happens a lot with psychiatric terms. Just like the word depressed is often used casually to describe somebody who's temporarily a bit sad, or PTSD is sometimes used to describe somebody who's just a bit traumatized, or OCD is used to describe somebody who's just a bit anal. And those are normal human experiences, and they don't cross the threshold for an actual clinical psychiatric syndrome, especially if they're, temporary and if they don't really impact the sufferer's functioning. Another example of the casual use of the word delusional might be when you're describing like a contestant from Britain's Got Talent who clearly does not have talent, or a psychiatrist who thinks that making video podcasts will make him rich and famous. So those are not actual delusions. They're more kind of like narcissistic, unrealistic beliefs, or even overvalued ideas. And I will talk to you later about overvalued ideas and what they mean. So now I'm going to tell you about one of the most fascinating and bizarre cases that I've personally been involved in. It's a criminal case where the offending was spawned from delusional beliefs. As with all my cases from all my podcasts, I'm going to keep patient confidentiality. So I've changed some minor details about the demographic of the patient, and also some minor details of the case which could identify them. Also, I would never talk about an ongoing live court case that's still going through trial. But despite all of that, the essence of my cases are 100% real. So if you're snooping around with your patient confidentiality protocols or GDPR guidelines, you ain't got nothing on me. So I'm going to tell you about the bizarre case of Mr. S. Mr. S was a Sikh man in his early 40s, and he was charged with racially aggravated criminal damage and also common assault. He had a history of mental health problems. He had a diagnosis of schizoaffective disorder that was exacerbated by illegal drug use. And I might do another podcast another time about exactly what schizoaffective disorder is and cases that I've seen, but just very briefly, it's kind of like a mixture of schizophrenia and affective disorders, which are mood disorders like depression or mania. So it's kind of the worst of both worlds. Mr. S was very familiar with psychiatric services. He'd had about 25 inpatient admissions to psychiatric hospitals by the time I met him, which is a lot, as I'm sure you'll agree. And those admissions were usually in the context of confrontation with his family members. When he was unwell, he would argue with them, he would smash up the house, but he wasn't objectively particularly dangerous or violent. Having said that, he did once incite a riot in a psychiatric ward, but that's a whole other story. And his offending was also fairly low level, I would say. It was burglaries and theft and possession of drugs. So not, serious violence. Mr. S had 3 siblings who were all quite high functioning. One was a barrister, one was a pilot, and I can't actually remember what the third one did. But what I'm saying is presumably they all grew up in a relatively stable, supportive environment. But not Mr. S. He went off the rails at a young age. He used drugs as an adolescent. He was a bit of a social outcast, and to be honest, I felt a bit sorry for him. Others would take advantage of him. They would use him to buy drugs for them. And even as a grown man, he was living with his parents. He did try for short periods of time to live on his own, but he just couldn't cope. He spent all his money on drugs, and he didn't have any money for food. And also nefarious elements of the criminal underworld used his house as a drug den, and he barely lasted 6 months on his own. So Mr. S's index offence, which I mentioned before, so that's the offence that brought him to the attention of psychiatric services. It happened in 2018. And the circumstances of the offence were very strange. Mr. S damaged holy scriptures in a Sikh temple. What he did is that he apparently intentionally walked into an area of the temple where you're not allowed in with shoes, but he was wearing shoes, and is also smoking cannabis at the time. So obviously this is very disrespectful to the temple. And he marched up to the Sikhs' religious holy book, which was like displayed on this platform in the middle of the temple, whilst others were around praying, including his own parents at the time. And he pulled away the ornamental cover of the holy book, and he actually ripped out one of the pages. And by this time, the other people had enough time to kind of react to what was happening. So all the men got up, they charged at him, and they started chasing him. And then Mr. S ran out of the temple, and he ran into a cinema down the road, and he tried to hide in one of the screenings, but the men chased him down, and they started beating him up, and he started hitting back, and there was just like this big scuffle. And the whole time throughout this, he was shouting that he was the 13th Sikh guru, which is obviously a delusional belief. By the way, I found out later that the film was 50 Shades freed. So the whole kerfuffle must have been quite disruptive for those watching the film, though arguably could have been more entertaining than the actual film. Mr. S was remanded in prison for a short period of time, and then he was transferred to a psychiatric hospital, which is where I assessed him. And on the ward, he'd started expressing a whole host of delusional ideas, including insisting that his ex-girlfriend had been murdered, which wasn't true, and also that he was able to control other people's minds. And he also said that his IQ was greater than that of Einstein's. And he genuinely seemed to actually believe these ideas. So when I assessed Mr. S on his ward, he was very disinhibited, and he was like overly friendly, which I think was a manic element of his schizoaffective disorder. And throughout the assessment, he kept making these odd comments. So when I very first introduced myself to him, he held up this like e-cigarette, and he immediately said, "This is not a weapon. You do not need to fear me." And throughout the interview, he spoke really quickly, but it was possible to interrupt him. And about halfway through the assessment, he just suddenly jumped up and said, "I'm very fit. Do you want to see how many press-ups I can do? Count my press-ups." And he just jumped on the floor and started doing these press-ups in front of me. And it was a very surreal situation, because I was actually counting his press-ups, because I didn't want to break the relationship and the rapport that we'd formed, because I wanted to do a decent assessment. And to be honest, I didn't want to be rude. He did about 60 press-ups, by the way, which, to be fair, it's not that bad. And Mr. S had a tendency to ramble, and he was also thought disordered with marked circumstantiality. So thought disorder, which is also known as formal thought disorder, is like a disconnection in the flow of somebody's thoughts and what they're saying. So it's really hard to follow their conversation, because they keep jumping illogically between topics. And circumstantiality is psychiatric jargon for taking a very, very long time to get to the point and constantly going off on tangents. As a parent of two young boys, it's something that I'm very familiar with. Circumstantiality and formal thought disorder are both softer, subtler signs of psychosis, as opposed to, for example, delusions or hallucinations, which are more obvious. Mr. S's reporting to me of his version of events of the index offence was quite interesting. So he was very suspicious of his parents the entire day, as he has been many times in the past when he's been unwell. And he was convinced that day that the whole family were actually going to the temple to carry out this like fake death ceremony for him, because they were jealous of him, because in his mind, he was the 13th Sikh guru, and he was about to change the whole religion. And as a kind of a side delusion, he was also in love with this Japanese woman who worked in a local clothes shop. And as far as I can tell, the feelings weren't reciprocated. But Mr. S was convinced that he was going to marry her, and because she was Japanese and he was Indian origin, he would spread the religion across the globe, which made in his mind, made the Sikh community jealous of him, which is why they were trying to fake his death. So this is why he felt justified in breaking up the event at this temple. What I think is quite interesting about this offence is that there wasn't actually really that much physical damage, and there wasn't really that much violence, certainly not serious violence, but obviously it was actually very offensive to the whole Sikh community where he grew up. And it was very embarrassing to his family, who were well established within this community. So the advice that I gave to the judge in my court report was that Mr. S met the criteria of not guilty by reason of insanity. So that is a psychiatric defence, which I've spoken about in a previous episode, my very first episode of this podcast, the case of John T. Bravery, who randomly threw a 6-year-old French boy who's a tourist off the balcony of the Tate Modern. So go check that episode out if you're interested in that. So I opined that Mr. S did not know what he was doing was legally wrong because of his delusional beliefs at the time. Luckily, the judge was sensible and he listened to my report, and at sentencing, instead of sending Mr. S to prison, which is where he was headed, he returned to the psychiatric unit for a long-term treatment, which I think is fair because I think he was genuinely very unwell. And to be fair, I don't think he'd have fared well in prison. I think he was already very vulnerable and people were already taking advantage of him in the community. So you can only imagine what that would be like in prison, especially if he's, running around making all these bizarre statements and asking people to count his press ups. I think it's likely that he would have been targeted and assaulted. Also, another factor is that Mr. S was insightless, which often happens with delusions. So he didn't believe he was unwell. So he was refusing treatment in general, and in prison you can't enforce treatment on a prisoner against their will. Like, for example, you can't inject them with antipsychotic medication. That's a medication that I'll tell you about later on in this episode, whereas you can enforce treatment in hospital under the Mental Health Act. So I think if Mr. S did end up in prison, he would not be medicated, not be treated, and his mental illness would have deteriorated even further. Next, I thought you might want to hear a breakdown of the different types of delusions and how we psychiatrists categorize them. I'll also talk about delusions that fit into specific diagnoses of mental illness. First up, persecutory delusions, also known as paranoid delusions. These are the most common type of delusions that we see in schizophrenia, and they're very common within the patient cohort that I see in forensic psychiatry, within courts, prisons, and secure wards. Obviously, this is a common presentation in patients who have mental illness who've reacted with violence. Persecutory delusions that I've seen usually involve the theme of being watched. So, for example, people believe that cameras are planted everywhere, or that spies are following them, or that random people are watching them or are talking about them. Another common persecutory delusion is the belief that they're being poisoned or drugged. So I must have seen probably over 20 patients in my career on wards or in prison who only eat packaged food that they can open themselves, so they know it's not been tampered with. An example would be the Russian woman, Miss R, that I spoke about earlier. Just as a sideline, another interesting aspect is that as a psychiatrist, very occasionally, I can't really figure out if what the patient reports is actually delusional or if it's reality. So I'll give you an example of a case that I saw last year, which really illustrates this point. I saw a young woman in her early 20s, we'll call her Miss C, and she was charged with grievous bodily harm with intent, and she was remanded to prison. And during her index offence, she went into a flat that she used to live in with a boyfriend but had moved out a couple of months earlier. And according to her, the people who lived there were all drug dealers. And she went up to one of the main drug dealers with this machete and she stabbed him across the chest. And she claimed, both in the police interview and also later when she spoke to me, that this man had threatened to kill her and her whole family if she spoke to the police about what had been going on in this flat, all the drug taking and the drug dealing, etc. And according to Miss C, he even showed her a gun to threaten her. So she said that all the flatmates were emotionally abusive towards her and they were gaslighting her. So in case you're not familiar with the term gaslighting, it's a relatively new term. It refers to a specific type of manipulation where they get you to question your own reality, your own memory, your perception, and even your own sanity. So in Miss C's case, these flatmates were allegedly making up stories intentionally to make her paranoid. So, for example, they would try and convince her that her boyfriend was cheating on her, and they would have these long, convoluted conversations about this, and they would show her proof, such as showing her photos on their phone. But then later on, sometimes that same day, they would deny that the whole conversation had took place, and they would like delete the photos. So according to Miss C, she would frequently hear them talk about her, but then when she confronted them, they would just deny this, and they would tell her that she was being paranoid. And Miss C claimed that they'd also tell her that she'd done certain actions or tasks when she couldn't remember what she'd done, because they were trying to convince her that she was mentally unwell. And these were fairly basic things. So she gave me an example. A couple of times her flatmates, she would tell her flatmates, I'm just popping out to get a pack of cigarettes. And they would say, but you just did that half an hour ago. And then cigarettes would suddenly appear in her room, and she was convinced that they were planted there to make her feel that she was going crazy. Now, the problem that I had when I was assessing her was this. All of what Miss C said was feasible, right? And it could be true. But on the other hand, she said that she was generally quite paranoid, and she generally felt unsafe. Even when she was walking on the streets, she believed that random people were talking about her and were laughing about her. I think another relevant factor in this case was that she was using drugs heavily around this time. She was using amphetamines and cannabis that were supplied to her by her flatmate drug dealers. And those are both renowned for causing drug-induced psychosis or paranoia. There was some evidence in the witness statements that I examined, and there was a lot of description of supposedly paranoid statements and psychotic behaviours, but these are mostly from her flatmates and also from the victim who she ended up stabbing. But then again, if what she was saying was true, that they were gaslighting her and trying to make her look mentally ill, then would that evidence be reliable? I don't know. It's usually quite helpful to know when I'm assessing a defendant if they've got a mental health history. And Miss C didn't really have any previous diagnoses. She had one previous suicide attempt from many years ago, but that didn't really indicate to me whether she'd ever been psychotic or not. If she had previously suffered psychosis, then that would have increased the chance of her suffering psychosis again, though obviously it doesn't, prove it. So I tried to get a handle on how Miss C's mental state had been in prison by speaking to one of the nurses from the mental health inreach team, which is like the psychiatric team based in a prison. And they'd only assessed her once in 2 months, and they didn't really give me any answers. In fact, the picture they gave me was quite muddled. She was seemingly not psychotic for most of the time that she was in prison. She was getting on well with other prisoners and staff and having normal conversations. But at the same time, there were some reports of her talking to herself in a cell. Now, I fully acknowledge that this could have been anything. It could have been boredom or frustration. But then again, it could have been auditory hallucinations. She could have been hearing voices, which would be an indication of psychosis. So it's a very mixed, uncertain, murky kind of picture for me, and I didn't really know what was going on. So unfortunately, in this particular case, I could not give the court a definitive answer in the court report that I wrote, which I have to say was very frustrating for me, because as a forensic psychiatrist, that's my job, right? And if I'm not able to give a definitive answer, it makes me feel a bit impotent, really. So all I could say in my court report was that Miss C was probably paranoid around the time of her index offence, and it was probably related to drug use and also part of her natural suspicious personality. I couldn't rule out an underlying mental illness that was causing delusions, though I said that on the balance of probabilities, this was unlikely. So from my perspective, if I did say that Miss C had a mental illness, and if she didn't have one, then this might have led to unfair leniency in the trial. I mean, she injured this man horrifically across the chest. I saw pictures of the injury in the case papers, and it was like a really severe, massive gash, and he needed plastic surgery. And I don't really know whether what she was saying was true, so I don't know if he actually was a drug dealer or if he actually threatened her or not. But on the other hand, if I said that Miss C definitively didn't have a mental illness and she did, well, that also could be quite unfair on her, because she might not have had full responsibility or culpability for her actions. In terms of criminal culpability, again, this is something I talked about in my first episode of my podcast, so go check that out if you want to know a bit more about that issue. So what I said to the court in my report was that at the time I assessed Miss C, which was about 2 months after her index offence, she did not meet the threshold to be detained under the Mental Health Act, so it wasn't appropriate to transfer her to a psychiatric unit. So instead, she went back to prison, and I strongly recommended that she needed to be observed more regularly and thoroughly by the mental health inreach team, and that they should sort of, bump her up their long waiting list. And I contacted them specifically, and I sent them a copy of my report. And my rationale was that I was only able to assess Miss C for about an hour during my medico-legal assessment, whereas the mental health in-reach team have the advantage of being able to see her longitudinally over many weeks. So hopefully they should be able to definitively ascertain whether or not Miss C had an underlying mental illness or not. So that is persecutory or paranoid delusions. Now I'd like to talk to you about the other types of delusions. From my own clinical practice, I would say that the next most common type of delusions are delusions of grandeur or grandiose delusions. They're usually the belief that you're either famous or omnipotent or wealthy or powerful, or that you've got special abilities. So an example of that would be Mr. S, who I discussed before, who believed that he had an IQ greater than Einstein. These types of delusions are particularly common in manic psychosis. So that's the manic episode of bipolar affective disorder, when it's so severe that it leads to psychotic symptoms. Other relatively common delusions include the belief that people can read your thoughts, which is known as thought broadcasting, and also thought insertion, which is the feeling that other people are putting thoughts into your own head. And there's also delusions of control, which is a false belief that other people or some kind of external factor or agent is controlling your general thoughts or your feelings or your impulses or your behaviours. And I've certainly seen many offences where the defendant has, as far as I can tell, genuinely believed that they were not physically in control of their actions, and something else or someone else was making them do certain criminal acts, usually in the form of like lashing out and violence. Incidentally, just to drop some high-level psychiatric knowledge on you, the three types of symptoms that I just mentioned, that's thought broadcasting, thought insertion, and delusions of control, they're three of Schneider's first-rank symptoms of schizophrenia. So they're about 7 in total, and that means that they're diagnostic of schizophrenia. If those symptoms exist, then the patient almost certainly has schizophrenia. Pathognomic is the word that we use in psych jargon, which means characteristic of a particular disease. Another relatively common delusion is delusion of reference. So that's a false belief that things, so what other people say, events, objects, or neutral aspects of your general environment have personal meaning or personal significance for you, for the sufferer. An example would be the belief that newspaper articles about completely random topics actually contain like coded words or secret messages for you. They might be insults or they might be instructions for you occasionally to commit a criminal act or violence. So I remember once seeing this Scottish man who was convinced that car registration plates that had like letters from his surname were somehow mocking him, and that he actually went out with a baseball bat and smashed up a car outside of his house, which incidentally was a Porsche. And I can only imagine that the insurance premiums after the event must have been horrific. Other rarer delusions include Cotard's delusion, which is a false belief that you do not exist and that you're dead, which is particularly common in psychotic depression, as are delusions of guilt or of sin or of self-accusation. So that would include the woman that I mentioned earlier, who was preoccupied with the devil trying to kill her because of a sin that she committed years ago, which is that she had an abortion. Delusional jealousy is another one. So that's a false belief that your spouse or your lover is having an affair, even though there's no actual physical proof to back up that claim. And clearly that can lead to domestic violence. And there's also erotomania, also known as the delusion of love, which is a false belief that somebody else is in love with you. Some of the delusions that I mentioned are very rare, although I have actually seen at least one of every case of what I've just mentioned at some point in my career. And maybe I'll tell you about those specific cases in future podcasts. But right now, I'd like to talk a bit about diagnosis, so about how people with delusions fit into diagnostic criteria. I've already mentioned bipolar affective disorder. Schizophrenia clearly is a syndrome that commonly has delusions as a feature, as well as hallucinations. So auditory hallucinations, hearing voices are the most common type. Then there's severe depression, which, as I stated earlier, is associated with nihilistic or guilt-laden delusions, such as Cotard's delusion. Other types of disorders which involve delusions, like dementia or drug-induced psychosis, which I mentioned before. So that's when you take illicit drugs, usually cannabis or amphetamines, and it causes like a temporary state of psychosis. And then there's also delusional disorder. So delusional disorder is often confused with schizophrenia, but they're actually very distinct illnesses. In delusional disorder, unlike schizophrenia, the functioning of the sufferer is generally not impaired. So they can usually work, or they can hold down a relationship or family life relatively normally, to a degree at least. And their behavior is not usually odd unless you actually talk about, or if you confront them about their specific delusion. So if you push those specific buttons in these people, they come out with this very bizarre conspiracy. So as an example, I once saw a man who repeatedly made reference to a delusional belief system. He was convinced that he was part of some experiment, and he actually thought his ex-partner was involved in this, and he kidnapped her, which led to him being arrested and transferred to a low secure psychiatric ward. So this was his index offence. And when I saw this man, he believed that everything and everybody was fake and was part of this experiment, including myself, including the other psychiatrists on the ward, the actual entire ward itself, and all the staff. So this happened not just with the staff in the hospital, but in the court where his case was being heard. And he even thought the judge was fake and was part of this experiment. However, outside of this, his overall presentation and functioning was fine on the ward. It was hard to distinguish him from the nursing staff, to be honest. And he was eventually diagnosed and treated for delusional disorder. Now, I'd like to talk about overvalued ideas. Right, these are similar to, but they're distinct from delusions. They are unreasonable and sustained beliefs that are maintained with less than the delusional kind of intensity, which basically means that the sufferer is able to acknowledge at least the possibility that their belief might not be true, or there's another aspect of looking at it. So you might not have heard of the term overvalued ideas, but you certainly would have heard of the disorders where they're prevalent. Anorexia nervosa is a very common example. So that is an overvalued idea, but not technically a delusion. That is when somebody believes they're fat when they're actually underweight. But for the diagnosis of anorexia, it's not just the overvalued idea. You have to have the behavior to match that idea. And as you probably know, that involves things like eating very little, missing meals, being obsessed with your weight and weighing yourself continuously, making yourself sick, purging, vomiting, etc. Another example of an overvalued idea that you might have heard of is body dysmorphic syndrome, or body dysmorphic disorder, which is a mental disorder where you can't stop thinking about a perceived defect of a flaw in your appearance. So common examples are having a big nose or having like crooked teeth. The flaw might be minor, or it might not even exist, or it might not be seen by others, but you are so embarrassed and ashamed and anxious that you might actually avoid social situations or even go to a plastic surgeon to resolve the issue. But more likely than not, even after the operation, you will not be happy with the results because of this overvalued idea. One of the last topics I'd like to discuss is about how you treat delusions. So delusions are notoriously hard to cure. They take a long time compared to other symptoms of mental illness, such as hallucinations or like general agitation. Psychiatrists usually treat them through medication, and less often they enlist the help of psychologists to undergo like intense talking therapy. And as a psychiatrist, I would be the first to admit that these antipsychotic medications are not perfect. They have a range of side effects, from sedation to weight gain. Some give you diabetes. They can make you quite agitated. Akathisia is another common side effect. So that's a movement disorder, which makes it really hard for you to sort of stay still, and you've got this constant urge to move around. Ants in your pants is how one patient described it to me a long time ago. Antipsychotic medications can also cause cardiac arrhythmias, which is an abnormality in the way that the heart beats, and they therefore increase the risk of having a heart attack, and they can actually reduce your life expectancy quite significantly. So prescribing antipsychotic medication is like a balance. The psychiatrist has to weigh up all these very serious side effects versus a lifetime of chronic delusions, which can be absolute torture for their patients. I mean, just imagine being constantly paranoid for all of your life. Not only can it be mental torture, but it can actually lead to suicide, or occasionally it can make the sufferer quite violent or dangerous. And again, this is common in the cases that I see within the forensic psychiatry system. I see people with delusions that lead to repeated violence. Ideally, when a psychiatrist weighs up the pros and the cons of taking antipsychotics, the patient should be involved in that decision. But I have to say, in reality, the patient usually has no insight, meaning they don't genuinely believe they genuinely believe their delusions. They don't believe they're ill, so they don't want to take these medications, understandably. Before I finish, I just have to tell you briefly about another case I was involved in. I saw this man in court about halfway through last year, so around June, July 2019, and he had these delusions about an imminent virus. And he said that everybody would be locked indoors and whoever disobeyed this would die within days. And he also said that black people would all die. He said the virus would come from Africa. He himself was black and from Africa. So he wasn't exactly spot on, but let's face it, he was, freakishly close. I'm very aware that there are a lot of podcasts about anxiety and depression, and there's lots of stories of people who've overcome mental illness and have moved on. And that's fine, right? I think that's a good thing. And I'm glad that those stories exist, and I hope they are inspirational. But I wanted to create something different for a Psych for Sore Minds. I wanted a podcast that addresses the more severe end of the spectrum and more rarer mental illnesses. I've got tons of fascinating stories, some of which are related to horrific offences and blood-curdling violence. But it's also important to remember that my patients are also some of the most vulnerable within society. They often have a history of abuse or other social problems like drug use, homelessness. And I would argue that they're doubly stigmatised, once for their mental illness and then again for the offences they've committed. I've witnessed some heartwarming tales of people who are once considered by some to be the dregs of society, who've overcome almost impossible hurdles and have shaken off the shadows of their pasts to end up living fulfilling lives. And I wanted to give those patients a voice, because I think we can all learn something about the human condition and about resilience, regardless of whether or not we personally suffer from mental illness. And along the way, I'd like to teach you a little bit about the clinical details and the technicalities of the psychiatry and also the medico-legal aspects behind all of it. But don't worry, I'm not going to bog you down with technicalities and information, because to be honest, anyone can find that stuff online. So for me, my patient stories and my own experiences are far more fascinating, and there are no other podcasts that share these insights as far as I'm aware. So those are the areas and the aspects that I'll be focusing on. So I'm quite new to this. Right now, I'm planning to make one episode a week, which will be released every Tuesday. And I'll be doing both a video version for my YouTube channel as well as an audio version. And as well as criminal cases, I also deal with many other medico-legal areas, including family courts. So, for example, assessing parents who have mental illnesses to see if they're fit enough to look after their children, and immigration tribunals, employment tribunals, and also a significant proportion of my work is for the civil court. So I'll be talking about all these different areas. And I'll be selecting some of my more tricky cases that I've been involved in and how they affected me and how they shaped my outlook as a psychiatrist. So I've got a few topics in mind for the near future, including coroner's court cases that I've been involved in. So that includes a case where somebody was assessed to be sectioned, was not detained under the Mental Health Act and was discharged, and they immediately left the assessment and went on to commit suicide. They actually jumped in front of a truck. So that's pretty horrific, obviously. I'll tell you about what I thought of the standard of the assessment at that time and the evidence that I had to give in coroner's court. And I'll also talk about the difference between this type of case, coroner's court case, versus similar cases with clinical negligence, where breach of duty has also led to a patient committing suicide. And another podcast, I'd like to talk about suicide attempts and serious deliberate self-harm in general, including cases that I've seen. So how some of these presentations can be a cry for help versus some of them are a genuine intent to die, and how a psychiatrist such as myself has to make this distinction. And I think also it's important to acknowledge what happens if we get this wrong. I'd also like to talk about when patients fabricate or exaggerate symptoms of mental illness. So they do this to be absolved of the responsibility of their crimes or to get leniency from the judge, or to be sent to psychiatric hospital instead of prison. I can tell you about cases that I've seen, including once where I was duped myself. So next week's podcast is going to focus on the stigma of mental illness. I'll be interviewing a young man named Osama, who has a very unique story So he's now a final year medical student, but in his first year of medical school, he had some serious issues with his mental health. And these kind of spiraled out of control, and he even suffered from psychosis at times. So he's going to talk us through his experience of being hospitalized and of recovering, and most importantly, his experience of the stigma that he felt from others, from colleagues, and from his peers at medical school. And he's going to talk about how this whole experience affected him and shaped his future career as a doctor. Then I'm also going to talk about my experience of the stigma of mental illness from the public and even from other doctors. And I'm always open to suggestions. So if you're listening or if you're watching this and if you have any particular ideas, anything you'd like me to dissect from the perspective of a psychiatrist or to inform yourself or other people, then please hit me up. I'm all ears. So subscribe to our YouTube channel, follow us on Instagram, like our Facebook page, and submit an episode idea or any questions to our email, which is psychforsoreminds@gmail.com. Until next time, stay euthymic, homies.